Hello, good afternoon, everybody. We'll be starting our panel now on reducing the environmental harms of care. And we have several wonderful speakers here to talk about what they've done in their own health center or in hospital about decreasing the environmental impact of clinical care. Their full bios are on the collaborative website, but I will give a brief introduction. First, we have Alina Zgardau. She's a third-year medical student at Western, and her research interests include environmental sustainability, and she's working with Dr. Perlikowski on surgical tray optimization for ENT surgery. We next have Dr. San An, who's a colorectal fellow and is pursuing a Master of Science in Quality Improvement and Patient Safety at U of T, and he finished his residency at University of Ottawa. Next is Dr. Michelle Shin. She's a PGY5 in respirology, and her interest is in minimally invasive procedures, and she does a lot of work, I know, in the area of health systems decarbonization. Elisabeth Perlikowski, who I've learned a lot from on Zoom, so it's nice to meet her in person, who is at SickKids as the Energy and Environmental Sustainability Program Manager. We have Mike Apostol, who is a dedicated champion for sustainability and has taught me everything to do with healthcare engineering and how it pertains to sustainability. He's a wonderful resource for our community, and he draws on expertise to boost energy efficiency through HVAC systems, lighting, steam production, as well as many other things. He is the lead of the National Nix the Nitrous campaign in Canada. We next have Dr. Deering, who works in the Division of Long-Term Care in the Department of Family and Community Medicine at Sunnybrook, and she's one of their leaders in environmental sustainability at Sunnybrook. And we have my friend, Dr. Ng, who is a pediatric anesthesiologist and co-chair of the perioperative care unit greening committee at SickKids, and has done wonderful work in greening the entire surgical platform at SickKids. So we will get started with Alina.
Hi everyone, my name is Alina, and today I'm going to be sharing with you our QI initiative to reduce costs in the carbon footprint by optimizing the head and neck minor dissecting surgical tray. Dr. Perlikowski received an MSO Opportunities Grant for this project. So as we know, climate change is one of the most significant global threats to both the environmental and human health. Hospitals in particular have a significant carbon footprint, with the highest contributor being the operating room. In fact, studies have shown that 20 to 30% of hospital waste is due to disposable and reusable sterile materials. A promising strategy to address this issue is surgical tray optimization. By analyzing the instrument usage and removing rarely or never used tools, we can reduce the CO2 emissions, cut costs without compromising patient safety, and improve efficiency. So for our project, we had three key objectives. We wanted to optimize the ENT minor dissecting surgical tray using Cotter's change model and evaluate the outcomes associated with this. And thirdly, we explored whether optimizing a surgical tray is scalable to guide optimization across different specialties. So the QI project was framed using the Cotter's change model, KCM, and we are currently extending this approach to at least one high-volume surgical tray across various surgical specialties at LHSC, our London hospital. So for those who aren't familiar with the Cotter change models, there are 8 steps, and on the right of the slide, you can see how we applied it to our project specifically. So first, we highlighted how we established the urgency by highlighting the waste, cost, and environmental impact of unoptimized trays. We then engaged our stakeholders, including surgeons, OR nurses, and the MDR team, to lead and support the initiative. And this involved a diverse perspective and shared ownership. After that, we created a vision of change and communicated the value. And we did that by defining the goals and sharing the plans through meetings, lots of meetings, emails, and discussions. After that, we empowered broad-based action and generated short-term wins. We distributed surveys, we scheduled OR audits, and allocated the roles for the redesign. We generated the short-term wins through this ENT-specific surgical tray so that we could show how efficient and how optimization could show results in both cost and efficiency. And then we consolidated the gains, and we're still anchoring the change currently. So to begin this study, we began with data collection. We sent out surveys using Qualtrics, as you can see on the screen, and this was distributed to the ENT surgeons, the nurses, and the residents and trainees to evaluate the instrument usage. We then conducted interoperative audits so that we can record instrument utilization in addition to getting data from the surveys. So for the surveys, we had 15 respondents in total. 60% were surgeons, 27% nurses, 13% residents and fellows. And the first question we asked was what was the most common procedures that they use the ENT surgical tray, so that we can make sure that we allocate our audits towards those procedures in particular. And those were minor excisions, thyroidectomies, parathyroidectomies, and parotidectomies. So this is a little bit overwhelming, but highlighted on the left are all the tools that were in the ENT tray, and we focused on eliminating the rare or never used tools, and those are the ones where you see the orange bar graphs coming out. After that, we also asked of tools where there were multiple tools on the tray, how many of the tools are being used in total. So the light purple is the total number of tools, and the dark purple is how many on average do they actually use of those multiples. And as you can see, there's quite a significant amount where almost none of the surgeons said all the tools are always being used, but we focused on the least number of tools, which are highlighted in the yellow at the bottom. So after we got our surveys, we began the surgical audits. And we conducted 6 audits across different surgeons and procedures. On this side, you can see the chart that we used to highlight the tools which were never used, never rarely used, and that was across 6 different audits. Together with the surgical data and the audits, we decided to compile a list of 6 instruments which were ready to be removed from the tray. But before that, we wanted to ensure patient safety. So with our MDR team, we used a surgical pouch, as you can see in the picture, which separated the tools that we were going to eliminate completely, so that in the case that it did need to be used, the surgeons had it handy. This also allowed us to see which tools couldn't be removed from the tray due to incorrect data collection. So we held this trial for 5 weeks. Within the first week, we did add a tool back, which was the Kelly, and that was because it was consistently being asked for. So in total, we removed 5 instruments from the tray, and these are the tools here. We reduced some and removed 1 tool that completely from the tray, which was the pediatric section. So in total, we reduced it by about 12%. We saved the hospital approximately $52,000 annually, and we reduced MDR assembly time by 2 minutes. But most importantly, our CO2 emissions were reduced by approximately 107 kilograms per year. And that translates to about 45.6 liters of gasoline, 4.5 propane cylinders, 0.2 barrels of oil. So it's quite significant for just one little tray. And after that, we also sent a provider feedback, and overall, it had very positive feedback with surgeons asking which is the next tray to be optimized. Overall, we realized that there's some limitations with the potential recall bias when we were sending out the surveys, which we used the audits to have extra data for. Our CO2 estimates were based on an article, Rizan et al., and these may not fully align with our institutions. And tray optimization is a balancing act because sometimes it is nicer to have convenience or the reassurance that your tools are on the tray during surgeries than eliminated from. But overall, this ENT optimization showed how it could be replicated across different specialties, and that's what we're working on currently. So with our team, we're doing one high volume tray across each service line, including general surgery, urology, gynecology, ophthalmology, orthopedics, plastics, thoracics, and peds general surgery. And thank you so much to my supervisor, Dr. Julie Strykowski, as well as the master's students who helped out with the data collection and the help and dedication to the project, and the Department of Otolaryngology. Oh, sorry, those are extra slides, but thank you.
My name's San An. I'm one of the colorectal surgery research fellows from the University of Ottawa. So here to talk about sustainable scopes, switching from sterile water in single-use plastic bottles to reusable bottles with tap water for irrigation and colonoscopy. So I think we learned that there's a lot of greenhouse gas emissions produced in the OR, probably the highest emitting department. When we looked at other departments in the hospital, the endoscopy suite was also up there in terms of emissions. So we started looking at ways to reduce our emissions at the Ottawa Hospital. One of the sources we found was using these bottles for irrigation and colonoscopy. Most institutions in Canada, in North America, will use these single-use bottles using sterile water. And I hope everyone has finished lunch. Just as a disclaimer, I have a couple of videos here. This is what it looks like when we go in with a colonoscopy using sterile water, presumably here in this video. But you can see there's still a lot of stool and debris. Really doesn't make sense to be trying to use sterile water and keep things clean when we're entering the dirtiest part of the human body. This is what it looks like on the way back. It looks like sewer water, essentially. Again, doesn't make much sense to use sterile water. So, what did we start with? We did a scoping review first to look at what existing data there is. And we found a couple of studies from around the 2000s that took cultures between tap water and sterile water that's used for irrigation, and found that they had the same amount of positive bacterial growth. So really found no evidence to justify using sterile water here. At our institution, after overcoming certain concerns and barriers that I can talk about afterwards, if anyone's interested, we were able to switch over back in February. And during that time, we've diverted about 2,100 bottles, saving about 1,200 kilograms of carbon dioxide, amounting to approximately 510 million microplastics and nanoplastics. And then our projected one-year savings as a result of this switch is about 150,000 at our institution. When we extrapolate this to North America, where we perform about 18 million colonoscopies a year, and with US rates of about $50 per case, this is almost $1 billion a year in potential savings if everyone were to make the switch. After we implemented this change at our institution, we sent out a survey, had a 39% response rate from nurses, physicians, PCAs, MDRDs, and 100% of them had no concerns for patient safety. They actually noted improved workflow efficiency because you can just refill these bottles instead of swapping them out, and then environmental and financial impacts as well. One of my favorite quotes from the survey is from one of the physicians who said this is simple, safe, much more resource friendly and environmentally friendly, and let's be honest, the tap water is cleaner than the colon water that the patients come in with. This is especially true when we think about other uses of tap water in similar circumstances like tap water enemas that are FDA approved. So, when we think about this for more than like a few seconds, it just makes a lot of sense. We're trying to implement this, as much as possible. So if anyone else is interested in doing this at their institutions, I'd be more than happy to talk about this further. Thank you very much.
Hi everyone, I hope you're able to hear me okay. But my name is Michelle. I'm one of the PGY5s training with the adult respirology program at the University of Toronto. And I'll be kind of changing our focus to a slightly different kind of scope, one that looks into the lungs. So we were looking at the waste and disposal practices in the bronchoscopy suite. And I just wanted to take a moment to thank Dr. Christine McDonald for supervising me on this project. So this was actually a single center observational study. We looked at 14 consecutive bronchoscopies in the bronchoscopy suite at the Sunnybrook Health Sciences Center. And this kind of included a range of different procedures, including a generic bronchoscopy where we look through the anatomy, and then EBUS linear probe biopsies. So an EBUS stands for endobronchial ultrasound guided biopsies, and these were kind of minimally invasive procedures that are used for diagnostics of pulmonary pathologies. So this is a generic bronchoscopy setup. You can see kind of the black snaking scope there is what's reusable. It's cleaned and sterilized between each patient procedure. And then ultimately the rest of what's pictured here most are actually single-use items that are used for the patient. In the bottom right, you can see the kind of samples that we send off are in little plastic bottles that we call trap containers. So, creating a standardized, itemized list, we were able to see how much of our items were being used for each patient procedure. And across 14 procedures, it's a bit of a busy slide, but I'll just draw your attention to the fact that there were many, many items being opened and used, but there were actually also items that were prepared at each patient bedside, but some of them were being opened, but not used and being discarded as part of the protocol. The three that I'll highlight to you are items like lidocaine ampules, so the medicine that we use to freeze the back of the throat. Of 14 procedures, there were several that were opened, discarded, unused. Other areas that we saw this was happening were the actual sample containers, what we call the BAL traps, as well as the gauze that we use as well. Half of the gauze that was being opened was being thrown out without even being used. As a stark contrast, there are very few reusable items that we use, and most of those constituted personal protective equipment like reusable gowns or towels. Now, what does this mean for burden of waste? On average, for each procedure, so for each patient that comes in through the door, we were using about 81 single-use items per procedure, and only about 8 that were reusable. For personal protective equipment, 15 items were actually single use, and then only about 4 of those per procedure were actually reusable. When we kind of extrapolated this data out to the total number of bronchoscopies that are performed on average at Sunnybrook alone, that generates about 20,000 single-use items that are discarded per year for bronchoscopies alone. This is actually a gross underestimate of how much waste we're generating, because this doesn't account for, our project couldn't account for the kind of waste that's generated between procedures where our environmental health services staff come in and clean between procedures, and the kind of personal protective equipment and cleaning supplies that they use. Now, where is that waste going? When we looked at our actual bronchoscopy suite practices, we noticed that we had 3 bins in the suite, and all bins were lined with these yellow biohazardous bags. All of the waste was therefore going into these biohazardous bags. When we opened up these bags, we found that most of the waste looked like this. It's kind of plastic waste, or our gloves, or tubing. As you can see, most of those are actually not biohazardous waste. The definition of biohazardous waste is actually items that are saturated with blood or kind of internal human fluids that, so just like how you wouldn't need to go to the hospital to throw out your Band-Aid from home into a biohazardous bin, most of these items do not need to be in biohazardous waste. So what we observed was that of 100% of the waste that was being thrown out into biohazardous waste, only 7% was truly biohazardous, 75% should have been regular garbage, and 18% was reusable or recyclable. Of all of the waste that was being generated, 13%, so more than 10%, was actually being discarded, opened, but not even used. So that meant 93% of our waste was being misclassified as biohazardous. When we interviewed our staff afterwards during this project, some limitations that they noted were the fact that there just wasn't available receptacles to be able to recycle or kind of appropriately sort the waste, and also some gaps in kind of knowledge about what kind of waste was being generated. So why is waste sorting or segregation important? What I learned through this project was how our waste is processed at Sunnybrook Health Sciences Center. The red bag biohazardous bags are actually sent to incinerators. From Sunnybrook specifically, our red bag biohazardous waste is driven over to Baltimore and Maryland, the USA. Our yellow bag biohazardous waste is sent to autoclaves, and these generate different kinds of toxic emissions. So incinerators create toxic air emissions like nitrous oxides, aerosolized lead, mercury, and this can create pathologies down the line for a lot of communities. Autoclaves have an issue of their own. They generate thousands of liters of water waste each day and also can produce leachate, which is potential contaminated water sources. And finally, this has socioeconomic implications as well. In the USA, 80% of incinerators are located in low-income communities or communities of color, which ultimately has really poor kind of long-term health implications. And finally, this also has healthcare cost implications. Per 1 kilogram of biohazardous waste processed, that's on average costs 10 times more to process than the equivalent of 1 kilogram of just generic landfill waste. And so these are healthcare dollars that could be resourced towards more important things, including improving our patient care. So with that, I do encourage you to kind of reflect on your own practice and if things make sense, because I'm proud to announce that through the work of Dr. McDonald, there's already been a complete revamping of the bronchoscopy suite at Sunnybrook Health Sciences Center just based on these observations alone. And so it's really about the importance of, have you asked the question yet? And with that, that concludes my presentation. Thank you.
Hello, my name is Elisabeth, and I'm from Sick Kids. And together with the Sick Kids POCU Green Committee, especially the support from the POCU Green Committee co-chairs, which we have one of them here at the end, Elaine, and I'm included myself, we have carried out a project that focus on educating staff on proper sorting practices around biohazardous waste. And today I'll highlight our project approach and the impact. So in our OR, we knew that our yellow waste bags were super contaminated. And when we did an audit, we found that 75% of our, there's a typo there, 75% of our yellow plastic bags were filled with regular garbage and recyclables. And we knew that the only way to do this is to educate staff and to raise awareness. And so we knew it would be a behavioral focus, so it might be challenging to ensure that we achieve lasting results. So what we did is we started with creating a pretty detailed project charter that we questioned. We included how we're going to engage staff and what are we going to communicate and when, and who are going to be our sponsors and how we're going to involve our sponsors throughout the project, and what are we going to be measuring. And our goal from the start is that in a period of 6 months, we wanted to reduce the amount of yellow waste leaving the OR, and we also wanted to reduce the contamination rate by up to 50%. And we took a multifaceted approach. With the help of sustainability interns who joined a staff huddle in the OR at the beginning of each day, for 2-3 minutes to share, this is what you do for yellow waste, this is what you dispose for regular waste, and this is why we're bugging you every day. They attended over 100 huddles in the period of 6 months. We also did in-service and in-service with surgeons and anesthesiologists as well as nurses. We also looked at the layout of the bins in the OR, and with the feedback from staff, we reorganized it to make sense, to make the waste sorting much easier and clearer. We've collected data from performing physical waste audits every 6 weeks almost when the project first launched, and we took pictures of what was contaminating the waste and we shared this information. We assessed the contamination levels by OR service, and we also shared, and we collected on a weekly basis all the complaints, all the concerns, all the issues, all the feedback from staff, and we shared it with the core group. And we implemented continuous improvement. We started addressing the questions that staff had immediately so that they were aware of what is happening and why we're doing this. And in turn, this increased the adoption of the new practices. We also collected a number of data on a monthly basis and shared with the core group. And it took us about 2 to 3 months to start seeing the waste of invoices decreasing and the volume of waste leaving the OR decreasing. It's been over 2 years since the project started, and we continuously do physical waste audits on an annual basis, and we report all the measures quarterly to the core team. And what we've seen is that about 30 tons of waste was transferred, what used to be going regular waste, into yellow waste. Now it's going to either we're recycling or we're throwing out, excuse me, in landfill. And we have seen our biomedical waste in our OR reduced by over 70%. And according to our last waste audit, the contamination was decreased by 49%. What we took away from this project, and we're happy that over 2 years later, the changes are there still, is we took a collaborative approach. And we focus on communication, we focus on continuous improvement, and we focus on measures and reporting those measures. That was really important. But one of the most important things coming from sustainability is that the co-chairs who were from anesthesia, surgery, and nursing, they gave us feedback on what makes sense to them. And we were constantly adapting to reflect the communication material or reorganization of the bins. And I think that was one of the key successes of this project. Thank you.
All right, hi everyone, I'm Mike Apostol, and I'm talking about biodegradable PPE and why greener isn't always better. So vendors are persuading healthcare sites to switch to biodegradable PPE for items like nitrile gloves and masks. Their pitch: it saves landfill space, it reduces microplastics and ocean contamination, it creates renewable energy from captured landfill methane. Ultimately, what you're doing is saving the planet, and all for only a little bit more money. Healthcare leaders often view this as an opportunity to do something for the environment and promote a green initiative to their staff. But what does it do? So in Canada, almost all PPE waste ends up in landfills. This is an anaerobic environment where biodegradable PPE turns into carbon dioxide and methane, which is a greenhouse gas about 87 times more powerful or potent than CO2 over 20 years. The realities of our Canadian landfills are that there's minimal methane capture. Open landfill methane capture rates can be under 20%. So that means most of the methane that's produced during that biodegradation actually escapes into the atmosphere before the landfill is closed and sealed. This means very high greenhouse gas emissions from quickly decomposing items like biodegradable PPE, adding to the end-of-life greenhouse gas emissions of that product. Available landfill space is not a global healthcare issue like climate change is, in my view. So the vendor date claims really don't hold up. So it saves landfill space. This is true, but the space savings are negligible, and the greenhouse gas emissions far outweigh the space savings benefit, in my view. So for example, if your hospital disposes 25 million nitrile gloves per year, it would take 38,000 years to fill a landfill with that waste, which is typically only open for 20 years. The image on the right is the little bottom part is, that 25 million nitrile gloves. And if we're talking volume of space, this is all the gas that you've produced in the actual gas, not CO2 equivalent, which is actually like 20 times bigger than this. Their second claim is it reduces microplastics and ocean contamination. This is not an issue here, and Canadian landfills are engineered to contain waste, and we also don't dump our waste into waterways. The third claim, the methane becomes renewable energy. Only a small fraction of it is ever actually captured when the landfill is open. Most of it leaks into the air long before that energy recovery is possible. Generating electricity from landfill methane is far less efficient and emits far more greenhouse gases per kilowatt hour than grid-sourced electricity. For example, switching 25 million nitrile gloves, about 100 tons worth a year, to biodegradable would create around 4,000 tons of CO2 emissions, equal to adding 1,200 cars back onto the road, kind of the opposite direction that we want to go in for climate change. Rule of thumb, 1 ton of biodegradable PPE equals 40 tons of CO2e. Now, capturing landfill gas helps reduce unavoidable emissions. The most effective solution, though, is to keep biodegradable methane-producing products out of the landfill. So just a quick diagram of the life cycle of nitrile gloves. So PPE, like nitrile gloves, are often made from fossil fuels. When burned, it does not qualify as renewable energy. It is just burning fossil fuels. So you take that fossil fuels, you send it to a processing plant, you get your nitrile, and then it goes, regular gloves would go to the landfill and sit inert in the landfill for, till the dawn of time. Biodegradable gloves, though, will degrade, producing landfill methane and CO2, causing greenhouse gases. The stuff that is captured goes to a simple gas generator, producing non-renewable and high emissions electricity, and also CO2 from combustion. So go for a counterintuitive win. When vendors are proposing both options, make the choice to produce or to procure non-biodegradable PPE. It could avoid tens of thousands of tons of future greenhouse gas emissions. The decision isn't flashy, but it's the right one for the planet, your budget, and your healthcare facility's credibility. Bottom line, not every product labeled biodegradable or compostable is better for the environment. And sometimes the most sustainable choice is the one that resists decay and avoids turning into potent greenhouse gases in our landfill. So what can you do though? Use PPE appropriately. Overuse drives waste. Training and awareness campaigns are available from all the regular suspects that are here today too. Choose reusable where possible. They almost always have a lower environmental footprint. Support fact-based procurement. Ask for life cycle analysis, not just marketing claims. Get help investigating the choices. Sometimes what vendors tell you and reality is not, or aren't aligned. I had a vendor tell a whole group of us that there were no transportation emissions from single-use gowns because they were bundled in a surgical pack. And I had to speak up at that moment in the presentation and say, that is incorrect. You cannot say that. They definitely have transportation emissions. Reach out to your hospital screen teams, waste specialists, or organizations like Cascades, Canadian Coalition for Green Healthcare, U of T's Collaboration Center. These are all great resources. Consider how you can approach future PPE procurement. Establish procurement policies to avoid biodegradable waste, or biodegradable or compostable PPE, unless it will be managed in the appropriate waste stream to enable the intended environmental benefits. This is likely not going to happen. It all goes to landfill as far as I'm aware. And share this information with PPE decision makers like IPAC. If you're already procuring biodegradable or compostable PPE, evaluate if there's an opportunity to switch back sooner within the contract obligations. Reframe it. Switching away from biodegradable PPE will reduce thousands of tons of greenhouse gas emissions per year, avoid greenwashing claims, and save your hospital money. It's one of the easiest environmental projects you could do that saves money in the process. Thank you.
So I am not Danette, I am Susan. I was not supposed to be up here. Unfortunately, Danette had a family emergency, and so she was unable to be here today. So I am here to present about the project that a subcommittee of our Green Task Force worked on for a couple of years. In fact, we're still working on it. And that is eliminating the piped nitrous oxide in our hospital. As Anita said before, I'm a family doctor. I work in the Veterans Center. I am not in the OR, but I have been part of the planning team that has been working on this project for a couple of years. So these are Danette's slides. I'm going to do the best I can, so bear with me. So I guess the first thing that I would say, that we really worked hard on, was to have a really interprofessional team. We needed to involve all of the stakeholders that were impacted in some way by the use of nitrous oxide that was piped through the halls of our hospital. And so, nitrous oxide is an anesthetic gas, also known as laughing gas, and it is a potent greenhouse gas. And we had started to hear from other hospitals about their studies on how much of the piped nitrous oxide actually got to the patients and how much didn't. And we were hearing rather astonishing numbers. When we tested our own system, we found that in fact, we were leaking we couldn't find a leak, but we were leaking more than 95% of the nitrous oxide that was piped through the pipes in our hospital. So we needed to involve clinicians, we needed to involve all kinds of clinicians, so not just people in the operating rooms, but in a mother and babies unit, in dentistry. We needed plant operations and maintenance involved. We had to be in communication with our vendor. There had to be lots of communication and so on. We met very regularly, and we always ended our meetings with action points and, this is what's happening next. And I have to say, Danette really was the driving force behind this. So you need a really strong leader who's going to help advance a project like this. So these are just a couple of photos from two of our sites. So on the left-hand side, the big tank there, that was the big 5,000 kilo tank of nitrous oxide that was at the main hospital site at Bayview. And then this one here on the right was the manifold of a bunch of smaller tanks at a smaller site, Holland, where we do orthopedic surgeries. And so we first had to assess what do we actually have in the system that we have. And so that involved a lot of gathering of data. So there you see the large tank. So we had to map, what do we have, where is this stuff going, who's involved, and so we found that we had two very different situations. At the Bayview site, it's a much more complicated system than at the Holland site. The Bayview site, there was piped nitrous oxide in cath labs, in operating rooms, not just the main operating rooms, but the burn operating room and on the mother and babies unit. There was piped nitrous oxide going to interventional radiology, a couple of places in the cancer program. So outpatient sites as well. And then we knew that nitrous was being used sometimes in dentistry and in the birthing suites as well. And when we asked, they said, no, we don't use the piped nitrous oxide, we just use small tanks. Okay, fair enough. But at the Holland Center, much more simple system. There's 5 ORs, and that's basically it. So that was where we decided to focus our efforts to start. Sort of a proof of concept, if you will. So this is where a lot of work happened and a lot of collaboration, a lot of meetings. So we started to gather data. We were having folks that were weighing tanks at the beginning, weighing tanks at the end. We were tracking how much nitrous was actually used at each of the anesthetic machines. Making calculations from kilos to liters, and so that we could have, compare apples to apples. And then with that data in mind, understanding how much we were using actually clinically compared to how much we were paying for, which was not the same, we launched into a pilot project to see if we could, if it was, possible to change to just using the small tanks on the anesthetic machines. And so we did this in collaboration with the anesthetists at the Holland site. And again, started with some data. So our pilot project involved, things like weighing the tanks, measuring how much was being used, calculating how much was being wasted, and so on. And we basically were able ultimately to turn off the piped nitrous oxide at the Holland Center. What we found was when we compared using the small tanks to using the piped nitrous oxide, we reduced our waste of nitrous oxide by about 80%, even though the small tanks on the anesthetic machines were left open between cases. And Danette did a whole lot of calculations to sort of put this in terms that we might be able to understand from an environmental perspective. And that was equivalent to planting almost 1,500 trees and letting them grow for 10 years. So that's how much you would have to plant to offset how much we had been wasting. So on May 31st, 2024, we shut off the system at the Holland Center. We then moved, with this success under our belts, we moved to the main Bayview site, and again, a large interprofessional team. And ultimately, we were able to turn off the pipe nitrous oxide at the end of November 2024. And it took us about 22 months. We would have had to plant 22,000 trees per year and allow them to grow for 10 years every year to make up for the nitrous we were wasting. So we can celebrate that we don't have to make that calculation anymore. Thanks.
I'm Elaine Ng, I'm a pediatric anesthesiologist. I'm presenting on behalf of our team at SickKids with representation from nursing, surgery, sustainability, and environmental services. The aim is to describe our journey in moving towards an environmentally sustainable perioperative care unit. It's always good to reflect on what we've done, but I was inspired to write this up because when we went to a conference last year, some of our anesthesia colleagues were wondering, how do we get started? I thought, what do you mean, how do you get started? Just start. And so perhaps it's good to talk about it, so maybe the lessons learned. How we started was, there was the call for a representative from our hospital to contribute to the Sustainable Operating Room Scorecard that was led by Tazan. So they called the hospital, and since I was the loud one, I was sent to this meeting. And we established our greening committee, and so we're co-chairs with stakeholders, and then we had some meetings, and then we invited guest speakers to come and inspire us. And then the other great thing was that we managed to get some sustainability interns. They come for 4 months at a time. These are great. They're young people, they're smart, they're passionate, they can do a lot of things that we can't do, so it's great. Somewhere along the way I got roped into this other working group, which is also amazing. And these outside organizations help kind of define what we should be doing, can be doing, and what other people's problems are. Somewhere along the way, I also met people from Cascades and of course the collaborative as well. So I'm very grateful to all these people in these organizations. Sometimes I get mixed up which meetings I go to, just because it's about the same people. The impact is that we got rid of desflurane, we're doing low flow rates, and proper biohazard waste management, as Elisabeth was presenting before. These 3 items were on the scorecard, but it also inspired other opportunities. So we stopped the routine placement of these IV stopcocks on the lines, and then we designed a surgical tray. So people say, well, so what? Great that you've done that. So I think it's always good to talk about GHG emissions and money. As our previous presenters have said, this is what gets attention. And so always talk about the impact and do some kind of management, even if you're not doing a proper QI project. So lessons learned, I think just do it and keep at it. Maintain progress, initiate other changes, and if there's no, pick some low-hanging fruit, and then maybe there's some snowballing effect. It's not always easy. We don't have paid time to do this kind of work, but there's ideas and enthusiasm, and you just roll with it. And of course, you have to keep at it, especially at our hospital, which has got a lot of new hires and trainees, so we need to keep talking with everyone, which is not a problem for me. So takeaways, reflections, I'm very appreciative we actually have a committee and to maintain the sustainability projects. And I'm also very grateful to the outside organizations, so we're very informed with current practices and opportunities. And as a location like this, I also hear similar practices and opportunities and projects people have been doing. And we need to keep going with education just because we need to reinforce information and inform other trainees.
Okay, I think we can take some questions. I just wanted to summarize from all of our speakers today in all the very highly successful implementations they've done at their centers. The common theme is they've decreased waste and they've saved money. So greening doesn't cost money. It actually, while saving carbon emissions, doesn't always decrease You're saving money as well, and I think that's what gets the attention of a lot of leadership in hospitals. So there's a mic here, and I think we may have a mic for people in the audience as well.
I think the lessons we learned from this project was, with most QI or change type of projects, is to get all the collaborators involved in as early as possible. The key players for this was with infectious diseases or IPAC, was with facilities, and then having an involved endoscopy manager, nurse, champion is crucial for this kind of change as well. And I think involving them early and making sure that their concerns are addressed as early as possible was the biggest thing. I can talk about some of the specific concerns they had, like, some of them was concern about the tap water going through the channels of the scopes and the mineral deposits, but one thing is like looking at the Health Canada guidelines for reprocessing of scopes, they actually recommend using tap water. So that it's addressing point by point things like that, and working with these different collaborators and making sure we have like this, we're on the same page, and that we can find a common ground. So that helped,
yeah. I haven't thought about that. Thinking on the spot. I mean, with the new greenwashing legislation, I think the hospital has more legs to stand on, because that has recently passed. And then just reaching out to your community to understand, all right, what is happening, what are they telling us, and can we fight back against it, I guess, and try and get better information out there. But I think it's more just environments like this where you share the information that you found out, and it's just communicating with everyone, and that's sort of the way to do it, and through obviously the partners that we have at Cascades here, Canadian Coalition for Green Healthcare, and U of T Collaboration Center. Yeah, I'll just add one thing. I have reviewed some vendors' life cycle assessments, and again, with all life cycle assessments, they're extremely complicated typically, and it's how you draw your boundaries around it, and unless you are a life cycle specialist, life cycle analysis specialist, like it's hard to know what's right and what's wrong. That's something that we've talked about in some of our group meetings, is like, can all the groups get together and hire like 2 LCA specialists and all they do is like healthcare LCAs? And I think that would be one approach, to just have that kind of deep knowledge to really understand what we're purchasing and what the best alternative could be.
Okay, thanks for the question. I think I can speak a little bit about that. We went to like the latest Planetary Health Alliance meeting, and a big focus on that is in terms of like the education aspect now, implementing it into education, like from a medical school level, but from like an undergrad level even, and just trying to integrate that so that future policies will have that in mind. At the same time, I think policy changes are sort of the higher hanging fruits that have a much higher barrier, but can have a much more profound impact from a wider net. But of course that does involve a lot more players and a lot more deliberation to do that, and it might not just be at like one institution, but rather like on a macro level. Sure.
Yeah, I'll definitely comment. Yeah, policy for sure is one of the fruit higher up on the tree. It's very difficult to do. But I will also note that just doing the low-hanging fruit is very difficult in the healthcare system. And then, you hear stuff about, colonoscopy stuff. I'm fairly certain we don't do that at my hospital, and so I will bringing that. That's a fairly low-hanging fruit, but just awareness and then having someone champion it. We just got someone from endoscopy on our green team that I'm already going to like send him this email on the presentation. So it's just even just doing the low-hanging fruit is sometimes challenging.
I can speak to the biohazardous waste. So at Sick Kids, we do have an issue with a lot of the contamination issues with yellow waste. I'm not sure how common it is in other hospitals, but when we were building kind of a business case for this project, we did not only include the savings, we knew they're going to come, we weren't sure how much, and we knew we're going to reduce the waste and have indirect environmental impacts. But what we knew is also we were not aligned with provincial and federal disposal guidelines, and that was also one of the key components that we were trying to communicate or share with OC Health and IPAC and get them on board to support us so we can co-lead the biohazardous waste initiative. So they were supporting us, identifying safety issues as well, and that helped to move the project forward.
I just wanted to comment from our perspective. So my project was on kind of looking at the bronchoscopy waste process, but I did want to also convey that, you know, the other work that we're doing that Dr. McDonald has championed at Sunnybrook Hospital was kind of working with industry to change thoracentesis kits. A lot of these kits exist at hospitals where we don't use more than half of the kit, and so again, waste that's being generated and discarded without even being used. And I think the major thing I've learned from working with her is that if someone doesn't ask the question, it doesn't get acted upon. And she's already worked with industry to be able to change the thoracentesis kit. So whenever I'm working at Sunnybrook, the kits are streamlined so that each item is something that I would use in the procedure. And so that's one project that's already happened, and all the kits have, at least in the pulmonary kind of clinic, has been switched over to those. And then currently we're working on a project at a national scale to kind of survey lung doctors across Canada and what kind of kits they're using, and if they understand that they actually have a say in how these kits are produced and what items are involved. So I definitely think that the question is, are you asking the question first of all, and what kind of question you're asking? And I think it's been really wonderful for me to be able to see that it's come into play just in the last few months at Sunnybrook to begin with.
I would say it's not easy. So there are some projects like the nitrous project that I presented that it is pretty straightforward. The system was on, now it's off, and the tank that you saw in that picture is gone. The manifold is gone. And so we can say, you know, we no longer purchase X amount of nitrous, and we only purchase this amount, and so on. There are many, many other projects that we have been working on, and you know, we report to one of our executive vice presidents, and she wants us to have SMART goals, and we're like, how do we measure what we're doing? And it's difficult. So it's certainly a learning process for us, and we're trying to come up with clear goals for each of the different work streams that we have, but it is one of the biggest challenges, I would say. And you know, you'd think a lot of the things we've been talking about have to do with waste, and you might think, well, that's something that we can easily measure because our hospital is, you know, has waste audits that they're supposed to submit and things like that. Getting that data has not been exactly easy. So it's a work in continuous progress.
So I just want to add one more thing. We had an example where a CFO sent us his MBA student for one of our projects to put together a business case because he wanted to see whether sustainability can actually produce some cost savings. That was the message that, and as we were working with the MBA student throughout the summer, and the project was to expand composting across the hospital. And of course that we can't sell our compost, so we can't make money. That's how we usually make money in waste. But with the help of the MBA, we actually, the MBA student, he actually understood that there's other benefits and other requirements for us moving towards sustainability. In this case, it resonated with him that there are provincial legislation that we're moving towards composting more because of how much methane food waste produce. So there is no clear path.
So your questions about desflurane at the pediatric hospital is quite easy to get rid of that because it's not our main anesthetic gas that we use. I don't know, Anita, do you want to take this one on? Ditch the desk campaign? Just because adult population, yeah, quick wake up, but there's is so many different ways to give an anesthetic. It's not about inhalation gases to start, but desflurane versus others for adults.
So there's no clinical evidence that there's benefit for desflurane. It's 3 times more expensive. And then the Canadian Anesthesia Society came out with very strong environmental guidelines as part of their guidelines to the practice of anesthesia in 2023, saying eliminate desflurane and nitrous oxide for use as general anesthetics. With that, so that's kind of like policy, it's not quite. If you are using desflurane or nitrous oxide as part of your anesthetic practice, you're not actually following best practices, and that's the strongest evidence we have.
Yeah, waste is not my specialty. We have a couple waste specialists at the hospital that are much more versed in it than I am. I don't really have a clear-cut answer for you. I don't know enough about incineration to really be informed to where I'd want my statements public. Sorry. There may be people here, I don't know if Mike or anyone else has other information on it.
I know that I'm not an energy specialist, but I know I had my conversations about waste to energy with my colleague who's an energy manager to understand how much energy is actually captured by incinerating waste. And it was his opinion that it was very minimal compared to, still the pollutants that are released during an incineration process. But we don't have any data on this. SickKids is a LEED certified facility. We have buildings that are LEED certified, Leadership for Energy and Environmental Design. And when we recertify with them, and when we report our waste diversion, anything that is considered waste to energy through incineration, it is not considered diversion. They are treating this as landfill. That give you some insight.
Yeah, I'll add one more quick thing. It comes down to trade-offs, right? So do you value the energy that's coming from that incineration higher than the impact of it going to landfill? Everyone has to analyze that and decide that themselves. It's the same thing for biodegradable gloves. You're trading off saving some landfill space versus a lot of greenhouse gas emissions. Everyone needs to sort of decide that for themselves, what's important. I obviously have my opinion on biodegradable gloves, but other hospitals and other facilities might make different decisions.
I actually toured the Diamond Incineration Plant in Peel to see what they were doing. They are set for expansion. There's a lot of concern in the community about the environmental pollutants that are being expelled in the local area because of the particulate matter. What I did get from that is that the waste to energy is not that efficient, and it doesn't actually generate that many kilowatts of energy. It's not particularly impressive at all. So when they say it's net zero waste, to me that's a greenwashing claim. But I'm not an expert, but I did go to the facility to tour what was happening. I think we have time for one more question. Yeah.
I think one of the reasons this project was so successful is because we were collaborating very closely with Elaine, who's an anesthesiologist, so she spoke the language and experience from what they needed. We also had one of the co-chairs as a surgeon, so she was guiding us of what to include and what not to include in the communication, how to communicate, when to communicate. We had a nursing educator involved, and she was guiding us. So we were adopting to what they were telling us. And for example, when it comes to bins, what we thought the setup was, they had a completely different vision. So all we were doing is we were adjusting, listening to them, and then once we implemented, we constantly were getting feedback, and we wanted that. We wanted to be present in the OR almost every single day and get their concerns, their questions, and respond to them as soon as possible. And I think this is the collaboration of everyone's exchanging ideas and brainstorming every single, in our case was almost a week, to say, are we on the right path? No, we're not on the right path. We have to adjust. For me, as not a clinical person, getting the feedback and the experience from the clinicians is super important, because we'll adjust and support the project in a way that'll resonate with the staff who will have to do this.
Yeah, I'll also just add, yes, the champions in what you're trying to do are always helpful. And then with all things like environmental related, it's gentle pressure relentlessly applied. That's our motto for our green team. We end every meeting with that, because everyone wants to do the right thing, but no one has time. But you can slowly, get people to do tasks bit by bit, and eventually you do achieve your outcome.
For my project with the surgical tray, there was quite a lot of pushback. Mike was one of our collaborators with the planetary health team, and I think the most important thing was getting engaged with stakeholders and having the engagement of the physicians and the surgeons. And every single time there was pushback, we would have another meeting to see how we can push forward. So just a lot of communication, especially when going into the ORs and when there's patient safety involved.
And I'll just add one quick point. For us, in terms of what was involved in the revamping of the bronchoscopy suite was, making it easy for your colleagues, because a lot of the concerns that were kind of relayed was the fact that there just wasn't time to sort. So what we did was the bins that were closest to the nurses in the suite that were lined with biohazardous bags were just replaced with regular bags, so that they just wouldn't be getting misclassified. And so that's already changed a lot of the habits in the bronchoscopy suite. And I think a lot of it just comes down to everybody's a working human, they're busy. If it takes 10 extra minutes for each patient to do something, it's hard to do. So really making it easy for your colleagues to make that change as well, I think really helped in our case.
Excellent. Thank you very much for your kind attention, and thanks so much for our panelists for sharing your implementations and your experience.